Hello and welcome to the Scopewell Podcast. My name is James Leuthe. Today we're going to talk about global health equity, diaspora engagement, and what it actually takes to turn ideas into impact across borders. Joining me is Dr. Yvonne Commodore-Mensah, Professor and Associate Dean for Research at Johns Hopkins School of Nursing and co-founder and president of the Ghanaian Diaspora Nursing Alliance, gDNA. Yvonne, thank you so much for joining me today.
Thank you so much for having me, James.
So you wear many hats as a professor, a researcher running clinical trials in the U.S. and in Africa, and healthcare nonprofit leadership. There's a thread that runs through all of it. I want to pick that up. Can you share a bit about your background in healthcare and your journey to this point?
I'm happy to. I'll first share that, as you said, I wear many hats, but I first identify as a nurse. I started my career at the bedside in cardiac care. And what I kept seeing was the same patients that kept coming back with the same conditions, the same barriers, and the same outcomes. And so I realized that all I was seeing at that moment was what was happening at the bedside. And at that time, I didn't really know how they were described, these differences. I got to learn about health disparities, right? And these are preventable differences in health outcomes, whether it's by race, ethnicity, by a cultural background. A lot of these differences in healthcare outcomes are preventable. And so that inspired my journey to pursue research, and not just any kind of research, but research that is considered community engaged, but also taking the abundance of evidence that exists and translating it into real world settings. How do we get guidelines, for instance, translated into primary care clinics, but also to communities? What does it mean to maintain cardiovascular health? And I also think what's unique to my background is that I apply a local health equity as well as a global health equity lens. I must first disclose that I am an immigrant. I was not born in the US. And so I apply that lens to everything I do, because when I arrived in the US more than two decades ago, I also had to navigate the healthcare system and really understand how to access care, also how to speak the language and understand the differences in the different types of health insurance that was available. And so it makes me also sensitive to the unique needs of immigrant populations, but also populations that are considered underserved.
Thank you so much for that background. So a few things. You started as a cardiac nurse before making a move to research. Could you say a little bit more about specifically what you were seeing at the bedside that made you feel like the problems were bigger than individual care?
I'll provide a concrete example. So for instance, for cardiac patients, many of them may have what we call heart failure. So it's when your heart is not functioning well as a pump. And so often you'll have patients who may be admitted for a short period of time to manage their condition and to help get rid of what we call a fluid overload. And what I would notice is that there were some patients who would often come back for the same issues and would be readmitted almost every other 30 days. So every 30 days, they'll come back and they're readmitted in fluid overload. We manage their medications, and then we send them back home, and they come back every 30 days. That also got me interested in what was happening outside of the healthcare system. So we know that in terms of the causes of these disparities, it's not just access in healthcare. For some patients, when they go home, they may not have access to healthy foods. So foods that are low in sodium. For patients with heart failure, it's important that they don't consume foods that are too high in sodium, because that's how they end up back in the hospital with fluid overload. And for some patients who have to take medications, they may not be able to afford medications, or they may run out of medications. And so that also gets them back in the hospital. And for other patients, they may not actually understand the condition. So what are some of the ways to manage heart failure? What are the ways to comply with a therapy, whether it's medication or lifestyle changes, or when to actually seek care? So these are all the things that happen outside a hospital setting that influences whether or not someone is admitted, but also importantly is the need to understand how to prevent heart failure in the first place. And so that's how I got very interested in what causes heart failure and other cardiovascular conditions. And lo and behold, it's mostly related to hypertension or high blood pressure. So I became very interested in hypertension as a risk factor for heart disease, kidney disease, dementia, and other complications. So if we can manage hypertension well and prevent hypertension in the first place, then we can also prevent heart failure from occurring. And heart failure can be very deadly. So I apply a prevention lens to a lot of the work that I do. Yes, nurses and healthcare professionals should manage patients at the bedside, but we also need to prevent these cardiovascular conditions from occurring in the first place.
Let's pivot to gDNA. What led you to founding the organization?
As she said earlier, I do have my full-time job as a professor at Hopkins. And I also, as a student, became a member of a professional organization. The first professional organization I joined was the Preventive Cardiovascular Nurses Association. And that's where I got exposed to the collective power of healthcare professionals, either advocating for issues, developing patient education materials. And so that also got me interested in understanding sort of what nursing looks like in the US compared to what nursing looks like back home. So, as I mentioned earlier, I am an immigrant. I was born in Ghana. And so I often visited the hospitals, and I also got to see what nurses could do at the bedside and how they perhaps were not considered partners with physicians. But in the US, I would say that nurses have their scope of practice is a little more advanced. Nurse practitioners have more autonomy. And so, along with my co-founder, Dr. Matilda Decker, we thought that with our unique backgrounds as Ghanaian nurses at Johns Hopkins, and also having access to a wealth of resources and also people who are very talented and experts in their fields, how can we learn from some of these lessons here and support our colleagues back home to advance the nursing profession? So when we think about global health, often the framing is people coming from high-income countries like the US going to places like Africa and doing projects. And often those projects are tied to grant funding. And so what happens when you lose the funding or the project ends? Often many of these projects collapse and the team disappears. And so what's different about this diaspora model is that we have skin in the game. I have family back home. Most of our members are highly invested in the success of the organization because this is deeply personal. It allows us to mobilize healthcare professionals, not just nurses, but from all over the world. And people, I like to say, who are Ghanaian at heart. You don't have to have a Ghanaian passport. We welcome any and everyone who cares about global health, because if we uplift the nursing profession, nurses can do so much more to improve healthcare. But also, if you were to visit Ghana and you needed healthcare, we want to make sure that the care that you receive is from the highest qualified and skilled nurse possible. And we think that by creating this organization, we have created this bridge between nurses in Africa and on the continent with their counterparts all over the world.
So you mentioned PCNA. I think it's important for us to recognize you're still engaged with them and recently stepped into which role?
Oh, yes. So I became a member of PCNA about 16 years ago, and I'm currently the president of the Preventive Cardiovascular Nurses Association. So I get to do that in addition to gDNA. So yes, it's a lot of work, but honestly, I do think that it's very complementary because both organizations seek to empower and advance nurses all over the world.
And congratulations on that. So gDNA has grown to more than 3,800 members across multiple countries in just 3 years. What does that actually look like on the ground for your members? How does that translate into real impact?
So when we officially launched about 4 years ago, I have to say that this was a bold step. And we didn't take that step without consulting with nurse leaders on the ground. We spent about 6 months meeting with leaders, nurses, midwives to really understand our unique healthcare context because I trained as a nurse in the US. Yes, I was born in Ghana, but I, at that time, didn't have any experience providing care in Ghana. So through those sessions, we got to learn a lot and we heard from the nurses the things that mattered to them. They wanted more opportunities for professional development. They wanted more collaborations with their counterparts all over the world. They also expressed a desire for instance, mannequins, improving their skills labs so that they can apply all the concepts they are reading about in a textbook, but also get to, really practice in simulation labs. And so that gave us the courage to formalize the organization. And so we officially launched at the University of Ghana, and we actually now have over 4,500 members and all over the world. So people are not deterred by the fact that we have Ghanaian in the title or the name of our organization. In fact, we have members from over 30 African countries who are our members. So what does it mean to have established this organization that continues to grow? I'll tell you that we had a conference in Ghana 2 years ago, and I had one of the nurses who had practiced for about 15 years walk up to me, and she thanked me and our team for creating this nonprofit organization, this passion project, which is a volunteer-led organization. And she said, Yvonne, for the first time in my career, I feel proud to be a nurse. She went on to say that our organization had helped to dignify the profession because we had found a way to bring experts from all over the world to their doorsteps, to Ghana. We provided keynote presentations. We provided free CPR classes. We provided workshops on quality improvement and research. And many of them expressed that this was the first time that nurses and midwives in the country had that kind of avenue to not just learn online, but be in the same spaces as more experienced nurses, but also experts from all over the world. So I can tell you how gratifying it is every time we converge in Ghana. And every year when we feel like, oh, this is amazing, the following year, it always gets better. And for the first time this year in 2026, we made it an interdisciplinary conference. And so in addition to having nurses and midwives from Ghana and all over the world, we also had physicians and pharmacists in the same space because healthcare is a team sport. So as we grow, we acknowledge that it's going to take not just nurses, it's going to take all healthcare professionals to advance the nursing and midwifery profession, but also improve health outcomes for all.
Can you say more about what you think it unlocks when you bring all of these different disciplines together in person?
I think one of the things it does is it levels the playing field. We had a workshop focused on customer service in healthcare, and people were really surprised that of all the topics we could have picked, we picked customer service. And we selected that topic because after engaging with people who have been patients in hospitals and also reflecting on some of our lived experiences, we recognized that there was an opportunity for clinicians, nurses, physicians, pharmacists to have a customer service orientation and also allow patients to express themselves, ask questions. And so we had 2 physicians and a midwife who met over a period of 4 weeks to plan that workshop. And the midwife in this case also said to me, this was the first time she ever had an opportunity to plan anything with physicians. And so they planned the workshop and they delivered it successfully. And again, having nurses sitting right next to physicians and pharmacists in the same space, I think it created an environment where everyone's expertise was valued, everyone's opinion was valued, and everyone had an opportunity to learn together. And I think that it's important that we create these spaces where this hierarchy that often exists in healthcare, we find a way to eliminate that, because when we place patients at the center of any healthcare conversation, The ones who benefit are our patients, right? But a lot of these turf wars in terms of, well, who's in charge, it gets in the way. And our conference attempted to do that by really creating more workshops that are interdisciplinary. And the last one I'll share is we had a workshop on innovation. We had the opportunity to partner with Johnson and Johnson and Microsoft. They have this signature program called Nurse Hack for Health. And the whole idea is that we need to recognize that nurses are also innovators. And so we organized this workshop at the conference, but we had pharmacists and physicians also show up to this workshop to learn about innovation. And so by creating an avenue where you're at the table with not just nurses from the same region, but from all over the world, and also sitting with other disciplines, it really allows us to bring our best to the table, but it also helps us to value our unique skills and expertise.
What inspired the hackathon and what innovations came from it?
I'll share that what inspired that hackathon in Ghana was gDNA participating in the Nurse Hack for Health competition and actually winning in 2024. So we competed against a lot of hospitals all over the world. And the innovation that we proposed was that Ghana has a unique problem of unemployed midwives, but we also have technology as a tool. And we have point of care ultrasound devices that are handheld that can be used by midwives, especially in rural areas. So as we think about the healthcare workforce, in many parts of Ghana and Africa, there aren't enough cardiologists, for instance. Ghana has about 30 cardiologists for a population of 30 million. So really think about people in rural areas who may not have access to a cardiologist. So if you have a pregnant woman who has heart failure during pregnancy, if there isn't a cardiologist, can you train a midwife to use this technology to detect heart failure, but also refer them to get seen by a cardiologist? So that's the model that we proposed. And we won this hackathon and we were able to conduct this proof of concept. We brought about 57 midwives from all over Ghana. We were able to demonstrate that indeed midwives can learn how to use a point of care ultrasound. They can correctly identify different parts of the heart, any abnormalities. So we did that successfully. So that experience, one of the things it did was that it really showcased or highlighted the important roles of nurses as innovators in healthcare. And so borrowing from that experience and also learning from, what it takes to create a pitch and compete and also talk about sustainability and the business model, we said, we can't just stop there. We want to make sure that nurses across the country and across the continent get a taste of that, what it means to come up with a healthcare problem and try to solve it, not alone, but with your colleagues. So that's what our hackathon at the conference sought to do. And you had to be there. I'll tell you, the organizers said that was the most engaging and entertaining hackathon experience they had ever had because every single person in the room was really excited to learn. And that has been one of the biggest learnings from all of the work we've done with gDNA, that young nurses and midwives on the continent, they're hungry for more. And it's up to us, not just as gDNA, but other healthcare organizations, to consider how we can partner, collaborate, and share knowledge. And the last thing I'll say is that it's also taught us that innovation, as we think about innovation, the standard or traditional ways to think about innovation coming from high-income countries to low-income countries like Ghana, what we've learned through that experience is that we really need to focus on what we call reciprocal innovation, which acknowledges that knowledge does not necessarily only come from a place where there's an abundance of resources, but innovation, some of the best ideas can come from low resource settings. And we also in the US and the UK can learn from how nurses and midwives use very little resources to keep people alive. And so more than anything, I hope that through Mama CVD and all the work that we're doing demonstrates that there's an opportunity to value different sources of innovation, and an innovative idea that can change the world can come from anywhere in the world.
For the listeners, can you explain Mama CVD?
Yes, so MAMA CVD is an acronym that stands for Midwife Assisted Assessment and Monitoring of Cardiovascular Disease. So it's MAMA CVD for short. But it was designed for Ghana by Ghanaian nurses and midwives. And the whole notion was that we need to meet people where they are, especially in rural areas. And we can adopt what we call a team-based care approach, where traditionally a task that may be done by a physician or a cardiologist, we're not saying that midwives are replacing cardiologists. We're saying we don't have enough of them. So how do we effectively engage and utilize the limited resource of having about 30 cardiologists, but how do we also take advantage of having unemployed midwives who could potentially be hired to partner with cardiologists and go into communities where they actually already are. I learned quickly when we started doing health fairs in Ghana that if you go to, in Ghana, they're called CHIPS compounds. So they are community health clinics that are in every community. You may likely not find a physician, but you will always find a midwife. So you do have midwives who are not just delivering babies, but they're also providing primary care. And we want to equip them with the right tools, such as point of care ultrasound devices, but other technology to make their work more efficient, but also allow them to be able to detect heart disease if it exists. But more importantly, the last piece of this puzzle is connecting them, right, to cardiologists so that they can take on the management of heart failure during pregnancy.
Powerful. Where do you see the biggest opportunity for that kind of thinking to reshape care here? You mentioned reciprocal innovation.
We've learned a lot of lessons through Mama CVD. And one of them is that a lot of the midwives that we recruited, we could only train about 57 midwives, but we had over 500 people apply. And we had an interview process and selected a few. And most of these midwives came from rural parts in Ghana. And we were actually intentional. We wanted to make sure that we were selecting people who came from areas where the greatest needs were. So using that thinking in terms of access to healthcare in the US, we all know that the US ranks nearly last on most, I would say, health outcomes in terms of life expectancy, quality of care, health equity. When you compare the US to other high income countries, we have a lot of resources, but we're not doing great in terms of making sure people live, above 80 years, for instance. And we also making sure that people have access to healthcare. So a parallel to that is rural settings in America. So we know that in rural America, there are Americans who unfortunately don't have access to cardiologists. They also don't have access to pharmacists, and they often face a lot of the similar challenges that Ghanaians in rural Ghana face, which is a shortage of qualified healthcare professionals. So we think that, for instance, the Mama CVD approach could be applied in rural Mississippi, for instance, where we know that there is an issue in terms of a shortage of healthcare professionals. Can we adopt a similar model, not necessarily copy and paste that solution, but think about what components of Mama CVD could be adapted to the US context, and also consider what might be some of the barriers in terms of policies that are necessary to facilitate sort of the adoption of point of care ultrasound devices in rural settings. But there's so much potential, because if it can be done in Ghana, it can definitely be done in some shape or form in rural America as well.
What do most healthcare leaders get wrong when they're trying to turn ideas into outcomes?
I would say one of the things that healthcare leaders may get wrong is that they expect that as leaders, they would have all the solutions to every problem that their organization or institution may be facing. through the work that we've done in terms of gDNA and PCNA and other organizations I've been part of, the greatest lesson I've learned is the power of collaboration and valuing different thoughts, different expertise, and also creating space for different people to come together to brainstorm, to really first take a step back and understand the problem, because leaders may often have blind spots. We feel like we understand everything, we know everything there is to know about an issue, but just also being in a position of leadership may make you blind to certain aspects of a problem that your team may be very well equipped. They'll tell you if you listen, right? So I think it's important that leaders listen first, that they collaborate effectively. And I would say the prerequisite to collaboration and also listening is trust. I think it's really important that if you're leading any organization, people feel like there is psychological safety, that if you're brainstorming and they're coming up with ideas, that they're not going to be shut down, that they'll also get credit if they come up with a unique idea. I think sometimes there's a danger that people feel like if they share an idea in a group setting, then someone else is going to get the credit for it. But in the group setting, if we're all working together to solve one problem, I think when we think about who gets recognition, we should also be thinking about how to recognize the group collectively, so that the leader, for instance, is not the only one who's being seen and recognized, but people need to feel like they're in a trusting environment and that they know that their leader, whoever they're following, is someone who recognizes and respects them as well.
If the model you're building works the way you envision it, what does global health look like 10 years from now? And what is the diaspora's place in it?
Well, this is a good question, because there's so many ways that this could go. But the vision I have is that when we think about healthcare and how we train clinicians, for instance, why do we only train clinicians in the US? Why don't we have more structured programs that allow clinicians to, for instance, do a semester or two abroad? I'll tell you that through gDNA, for the past 2 years, we've had a global service learning program where we've taken about 10 to 15 students to Ghana to learn about healthcare in a different context. And from all the conversations we've had, from the health fairs that we've conducted with the students, it's been really remarkable to watch these students serve with nurses on the ground to learn how to do things. I've actually seen firsthand local nurses teach our students, how to do things, and then vice versa. And coming up with creative solutions right there on the spot as they're providing care to hundreds of people in the community. I think that that's my vision for how we should be training the next generation of clinicians and healthcare professionals. We need more of these reciprocal exchanges. So just as I described that we took students to Ghana for about 10 days, we need more opportunities where we are also bringing nursing students from Ghana to the US so that they can also learn. And if someone starts working as a nurse, a lot of organizations are starting to advocate for global credentialing. How do we make it easier, one, for people to train all over the world, but when they actually start working, we need to make it easier for people to learn from different settings or actually work in different settings. And I think that will really unleash so many opportunities in terms of thinking creatively about solving healthcare problems, because you can work in the US for 3 months and you could be stationed in Asia, in Africa, right, for a couple of months if you so choose. But going from one context to the next, I think may expose us to different ways of thinking, different ways of doing things that will ultimately make outcomes better for everyone.
Well, I think that's a powerful note to end on. Yvonne, I want to thank you for your time and for the work you're doing. This was a great conversation, and I think a lot of people are going to walk away thinking differently about where real change in healthcare comes from. So we appreciate you joining us on the Scopewell Podcast.
Thank you so much for having me. I've really enjoyed our conversation, and thank you to the guests for listening.